Hello, I'm Tamara Wignansky. I'm Jaffe IPOS president. I'm excited to present the first masterclass in strabismus surgery, which marks the beginning of a new series of IPOS workshops. We encourage all of you to provide us with feedback and share suggestions for future masterclasses, and your input will be tailored to make these events more of interest to you. So I hope you will enjoy the webinar and join other IPOS global activities. And without further delay, I will now pass the stage to Rosario and Giovanni. And I'd just like to thank all the moderators, the presenters, and the AAO team for always making these webinars in a seamless fashion. Thank you and enjoy. Rosario.
Well, thank you, Tamara. Good morning, good afternoon, and good evening, everyone. And thank you very much for joining us for the first webinar of our masterclass series in strabismus surgery. It's an absolute pleasure to kick off in this exciting masterclass series. And today, the session will be on the surgical management of the complete third nerve palsy. Well, my name is Rosario Gomez de Liano, and I am delighted to be moderating this session alongside with my colleague, Giovanni Marcon from Italy, please. Yeah. And together we will guide to this very special session. We are delighted to have 4 outstanding speakers with us, and each of them are among the most distinguished experts in the respective field, representing various parts of the world. They will focus especially on innovative aspects of the surgical management of this complete third nerve palsy, and we hope we can all discuss practical aspects that you can apply on your daily practice. We will have first Seyhan Ozkan from Aydin, Turkey. She is professor of ophthalmology. She works presently in Aydin Clinic, and she was past president of the ESA and president of the ISA, and she will be speaking on the pharmacological, surgical traction for the treatment of third nerve palsy. Then we will discuss this part, and we will go, next slide, please. Can I have the next slide, please? Then can I have the next slide, please? No. This one. Then we will have Linda Dagi from Boston. She works in the Boston Children's Hospital, and she's an associate professor at Harvard Medical School, and she will speak on the nasal transposition of the lateral rectus for the treatment of the third nerve palsy. And then we will have Federico Velez, that he is at the Leonard Abt Chair in the Pediatric Ophthalmology. He's a clinical professor of ophthalmology at Jules Stein Institute, and he will speak on the caruncular fixation and also on the superior oblique surgeries for the treatment of the third nerve palsy. And then after this block, we will have a very interesting talk from Donahue. He's on the Coleman, he's in Nashville. He's in the Coleman Professor of Ophthalmology and Visual Science, and he's the current APOS president, and he will speak on surgery for aberrant regeneration in the third nerve palsy. And we encourage all of you to participate through the Q&A question box. And once again, I welcome you all to the masterclass series, and I hand over to our first speaker, that will be Seyhan Ozkan. And if you can unshare my slides to be able to give the word to Seyhan. And here it is. And that's it.
So thank you very much. And do you see my slides now?
But yes, no, yeah.
Maybe if you close your video, that will be okay. And thank you so much. And dear moderators, dear colleagues, it's my distinct pleasure and honor to participate and speak at the IPOS webinar organized in collaboration with AAO. And greetings from Aydin, Turkey. And I'm going to speak about pharmacological or surgical traction for the treatment of third nerve palsy. And I have no potential conflict of interest to disclose. So unlike the other types of strabismus, in third nerve palsy, we have only two or sometimes just one muscle to restore the ocular alignment. As being the first speaker, I'm going to make a brief introduction about general aspects. So we need to wait for 12 months before surgery. Amblyopia prevention needs to be considered, and botulinum toxin may be considered to reduce antagonist contracture in acute stage, and prisms may be helpful only in selected cases. And we need to know whether is it congenital or acquired? Is there any diplopia? Is there any accompanying acquired loss of fusion, so-called as central fusion disruption? Is there any lateral rectus contracture and orbital fibrosis? Is there any function in the supraoblique muscle? Is it complete or incomplete? And is it partial or total? And the surgical methods briefly are lateral rectus weakening procedures of any kind, medial rectus resection, supraoblique nasal or temporal transposition, and lateral rectus nasal transposition with or without split, and medial wall or caruncular fixation of the globe. And in incomplete third nerve palsy, the options are much more. And the aim is primary position alignment, and there is a very limited area of binocular field of single vision, and this may be end up with more bothersome diplopia in some patients. And the major challenge is lateral rectus contracture and secondary orbital fibrosis due to shortening of orbital structures, and the diagnosis is done with a positive force suction test after disinsertion of the lateral rectus muscle. And because of that, there is a tendency to drift back to the exotropic position. So the traction or so-called stay sutures are in use in strabismus since a very long time, and the aim is to overcome restrictions by keeping the eye in a desired position during wound healing and scar tissue formation, and to alter both the mechanical balance and also the stability position of the eye, and additionally to stretch the orbital ligaments and septa to adapt to the new position of the eye. So in a way, to change the memory of the orbital structures. However, the traction period in the previous literature is highly variable. Some keep them as a couple of days, some keep them as 2 weeks, and some keep them as long as 6 weeks. So here you see the original description of John Lee from his paper. And this is, and so in this technique, he passed 2 double-arm non-absorbable sutures. He used 6 non-absorbable sutures. He passed those from vertical rectus muscle insertion sites, including a small scleral bite. And then these sutures are taken off from upper and lower eyelid. So I was lucky enough to learn this technique from my mentor, John Lee. Then I started to use those traction sutures, but we preferred to use the 5 non-absorbable sutures to reduce the risk for cheese wiring. And this is how the patient looks after surgery. And the sutures are tied over silicone bolsters. So by using traction sutures, the Morpheus group reported a high success rate as high as around 90% in recess resect procedures. And in a more recent paper, they reported favorable outcome by using them with birectus periosteal fixation. And in those 2 papers, the major difference compared to previous papers was that they kept those sutures as long as 6 weeks' time. So the problems were unpleasant time during this period. The sutures may tear off, there may be cheese wiring, and conjunctival hypertrophy may be a problem, and suture infection is a problem, and obviously pediatric age group is a challenge. So this is one of our patients. This is a long-standing congenital third nerve palsy with severe orbital fibrosis problem. So in this patient, we preferred supramaximal lateral rectus recession in combination with supraoblique nasal transposition. And we used them with traction sutures, and we kept those sutures as long as 6 weeks. So after removal of the sutures, you can see that the abduction is limited. And even in this very severe case, there was a small amount of adduction. And in this case, the right eye is blind, and the patient had a left third nerve palsy, had a previous eyelid surgery elsewhere, and he had very severe orbital fibrosis. So we prefer to fixate the lateral rectus muscle into the orbital wall and then combined this with superior oblique nasal transposition and added traction sutures. So this was the maximal point of adduction that we can pull the eye. And unfortunately, in this patient, the sutures teared off after 2 weeks. And this may be because we had to use 6-0 sutures in this case. And you can see that in postoperative second month, there was a small exodrift, but even with that, there was a limitation of abduction, and the patient was highly satisfied with this result. So if we compare keeping the traction sutures at 6 weeks or 2 weeks, it seems that keeping the sutures as long as 6 weeks seems much more beneficial for a better long-term stable outcome. So what do we mean by pharmacological traction? So we know that we obtain and we aim to get an overcorrection with some limitation of ocular motility when we inject toxin. And this effect is much more severe when toxin injection is combined with antagonist resection or transposition surgery. As you can see in this patient, there is a severe overcorrection and the eye cannot move. And this effect is so similar with what we see with traction sutures. And then this gave us the idea whether we can use this instead of traction sutures. And additionally, it is known that botulinum toxin augments the effect of conventional recessions, as we also previously demonstrated, and this was also demonstrated in paralytic cases. However, including our series, no reference was done for the fibrotic element. And we also considered that this might be an additional advantage to use botulinum toxin instead of traction sutures. And this is one of our patients. You see that this patient has a post-traumatic third nerve palsy, a long-standing case, and the right eye cannot reach the midline, and there's a small eyelid defect in the lower eyelid. So I didn't want to use traction sutures in this case. And this patient also had superior oblique palsy. So what we preferred was that we have performed a supramaximal recess resect procedure, and we also injected botulinum toxin into the recessed lateral rectus muscle. I prefer to put the scleral sutures first in order to reduce the manipulation after toxin injection. And this is how the patients appeared on the first day of surgery. You see there is a significant limitation of abduction. So when you do a resection in the medial rectus muscle, this limitation rapidly wears off. However, you can see that in this patient, after 10 days, the abduction is still significantly limited. Now, this is the effect of botulinum toxin, and the eye is in overcorrected period. And there is an ESO deviation, so the effect is quite similar with traction sutures. And this is post-operative first month. You can see that the abduction is still limited, and amazingly, this patient had small amount of adduction. And this is post-operative 2 years. You can see both abduction and adduction is limited, and there is a good stable result with a small binocular field of single vision. And the patient was highly satisfied. Again, a similar case. Third nerve palsy, toxin-augmented supramaximal recess resect, early overcorrection, and then good stable long-term result. This patient is a residual case. She had 2 previous operations, a left third nerve palsy, and we performed a toxin-augmented re-recession in combination with medial rectus re-resection, and this was also combined with right lateral rectus recession, early overcorrection, and good stable long-term outcome. So both with traction sutures and toxin injection, the eye is kept in the opposite direction. And the mechanism could be a possible increase in sarcomeral alterations. The soft tissue healing develops during the overcorrected period with stretching the orbital tissues by changing the orbital memory of those structures. And additionally, there may be a possible scar migration in the recessed muscle, either due to microbreaks at the muscle insertion during tension or by alterations in posterior anterior dynamics of the reinsertion. So in pharmacological traction, the major advantages are it is technically easy, patient tolerance is very good, it is possible to use it in children, and the overcorrection period lasts around 6 weeks. And the limitations are ptosis, and it's not possible to use it with hangback sutures because the muscle may move forward when you inject toxin into this muscle, and the efficacy in very severe orbital fibrosis may be questioned. So the take-home messages are: traction sutures may be useful to overcome lateral rectus contracture and orbital fibrosis, and it may be combined with any type of surgery, but keep them as long as 6 weeks' time. And botulinum toxin plus recession of the lateral rectus muscle in combination with medial rectus resection or supraorbital transposition may be an alternative to traction sutures, providing a pharmacological traction, and the early overcorrection is the critical key for a successful long-term outcome. And finally, I would like to remind you the next ESA-TOA APOS joint meeting, which is going to be held in Istanbul in June 11th to 14th. And I would like to invite you all to the magnificent city of Istanbul. And thank you very much for your attention.
Thank you, Seyhan. Rosario, have you any? We will do some questions. I don't see any questions from the audience up to now. So, Seyhan, may I ask you, considering your very good results with the botulinum toxin and this pharmacological traction, have you any specific indication where you would like to use original traction sutures or botulinum toxin from your experience?
Well, I must say that if in any way, if I can pull the eye towards the midline, and then toxin augmented recession works. And but on the other hand, it has to be combined with some pulling force in the adduction. This may be either with supraoblique nasal transposition, maybe either due to excessive resection of medial rectus muscle. I'm speaking about the resection as much as you can. And also, it may be combined with the more powerful fixations, as we are going to hear today, and from Federico. And so the major influence is altering the position of the eye during the early period. So if you can keep the eye at the end of the surgery in some way a little bit on adducted position, what toxin do is, as I mentioned in one of our cases, and to keep this overcorrected period longer. So when you resect the medial rectus muscle, it wears off easily. But the major difference is it's when some healing develops during this overcorrected period, even with a paralytic muscle, there is some granulation tissues and so on. So its pulling effect lasts a little bit longer.
We have some questions, and I will summarize all together from the Q&A box because they are mainly on the technique. So about the dose, if you do it pre, intra, or after the surgery, and if you use bupivacaine, and how to avoid, I add that myself, to avoid the diffusion when you are injecting intraoperatively.
Okay, so if we start with bupivacaine, I did not experience bupivacaine in these cases, but the major problem with bupivacaine is that the effect of bupivacaine starts later, but we need to obtain an early overcorrection. And on the other hand, in acute, if I see a patient with an acute third nerve palsy, so in third nerve palsy, we need to wait at least 12 months. It is a little bit longer than compared to other paralytic types. So the contracture develops very rapidly. If I can see a patient during the acute phase, I always prefer to inject botulinum toxin into the lateral rectus muscle to reduce the amount of the secondary fibrotic issues. And on the other hand, in those cases, my choice is to do the injection directly under view. One, I'm holding the muscle and I do the injection directly into the muscle bulk itself. And I prefer to use 10 units, but there is also some spread with it. But so when I see that there is the swelling of the muscle, I don't touch anything with the muscle and I just tie the sutures. That's why I first put the sutures, and then after injecting toxin, I just tie it up and then close it afterwards. And was there any other thing I forgot to answer?
No, the dose 10, and I think how to avoid the leakage. That was. Well, I think, Giovanni, we can pass. You are muted. You are unmuted, Giovanni. Giovanni, you are unmuted.
Sorry. No, there's an interesting question, very briefly, if you can answer, if you ever had this experience, Seyhan. Have you ever seen some side effects of the conventional traction, mainly on the intraocular pressure, which could be a concern in the pediatric age, for example?
Well, I have never experienced an intraocular pressure issue. And so while I was with John Lee, I also haven't heard any side effects like this. And but well, if we speak about techniques, I would like to say a couple of more words. So in John Lee's technique, the sutures are passed through the vertical rectus muscle insertion areas, but including a small scleral bite. So with Sixo, the cheese wiring effect is low. And in Jill Adams' paper, which is more recent, they used limbal sutures, but I think limbal traction sutures are more uncomfortable for the patient. So in our hands, the John Lee's technique seems much more comfortable in order to avoid any corneal complications and so on. But we haven't faced any case with intraocular pressure increase, no. The major problem is tearing of the sutures. And 5.0, with 5.0, it looks much better, yeah.
Thank you. So thank you very much, Seyhan. So can you introduce the next one, Giovanni?
Yes. Let me just, sorry, because I don't have the, so next speaker will be Linda Dagi from the Boston Children's Hospital, and she will speak about the nasal transposition of the lateral rectus in complete third palsy. Thank you.
Thank you very much for the opportunity to speak at this lovely webinar. I've been tasked with discussing nasal transposition of the split lateral rectus for third nerve palsy, which is really a wonderful technique, but not for all patients. So as mentioned, strabismus surgery for partial third nerve palsy in no way resembles surgery for complete third nerve palsy.
Linda, I am not seeing your slide. I'm seeing
your slides.
You're not?
Slide. No.
Ooh, I am, but I guess, let's see, let's escape this. You're not. Okay, I'm going to stop sharing and I'll reshare. I'm not sure why you're not. Let's try this again. Share. Let's try this. Are you seeing?
Yeah,
like
perfect.
Yeah.
Let's start again. Sorry about that. Okay. So once again, we're here to talk about nasal transposition of the split lateral rectus. So strabismus surgery for partial third nerve palsy is of course not the same as surgery for a complete third nerve palsy, because you have different decisions to make. Do you have a partial or complete third nerve? Is there any fusional potential which changes how you think about the procedures done? Or is this really a reconstructive procedure, or one where you have to manage diplopia? So in partial third nerve palsy, you can create a reasonable region of single binocular vision. So give a brief case. This is a lovely child with a brain tumor. She has a partial third. She had a recess resect on her left eye, the third nerve palsy eye for exotropia, plus a Faden to her contralateral lateral rectus to reduce the abduction. She had a, hold on, I'm not seeing my own slides. Here we go. An inferior oblique recession on the contralateral eye, the right eye, to match the elevation deficit on the left. And a severing of the anterior third of the superior oblique tendon on the left eye to extinguish the encyclotorsion, which is a common concomitant of partial or full third nerve palsy, as your inferior oblique is still left as an active muscle. I'm going to try to remove that here so we can all see. Okay, but the bigger challenge is a complete third nerve palsy. Here's a case with acquired CNS tumor near the cavernous sinus. The right eye is down and out, and the lid is held up with a lid crutch, which is an easy technique to use for patient with glasses, and you do not have to worry about exposure keratopathy. So not to belabor this, because we've discussed this and will further, for a complete third nerve palsy, you have to weaken abduction tone, which can be done in many ways, and I will not belabor these now because they will be discussed. And you have to strengthen adducting tone, once again, through many procedures, which can involve the superior oblique, hemitransposition of the inferior and the superior, if they're not completely paretic, a large medial rectus resection or caruncular fixation, nasal fixation of the globe to the periosteum, which is an extremely powerful and effective technique, or nasal transposition of the split lateral rectus, which both weakens abducting tone and strengthens adduction tone. So it's a sort of a complex one muscle procedure that does both at the same time. And if you have diplopia, you may have to think about managing the torsional and the vertical misalignment. So once again, you can consider all of those when doing a nasal transposition of the split lateral rectus. So this technique was devised to make a simpler and potentially more stable approach to treating subtotal or total third nerve palsy. The lateral rectus is split down its long arm, transposed using a gas hook to the contralateral side of the globe near the medial rectus. I like to do it with adjustable sutures, not to adjust the patient in the post-op area, but during surgery itself, you can adjust how much you transpose those split ends. What you see under anesthesia is what you get because it's a completely mechanical procedure. It involves no neurologic tone. At the current time, I always perform an ipsilateral inferior oblique myectomy and a superior oblique tenotomy, and you'll see why. And here's the view from above and below. Here's that split lateral rectus coming around to the nasal side of the globe, superiorly and inferiorly. Inferior oblique myectomy, that red fire button, and the superior oblique tenotomy as well. At this time, I also pre-place a 5-merceline on the nasal side of the tenotomized superior oblique, just in case I need it. It's kind of a chicken suture. If I cannot fully transpose the split lateral rectus, if I fail, I still can have use of the superior oblique in some fashion to adjust the alignment. The procedure centers the eye by balancing the medial and lateral tension on the globe. I like to think of it as the basketball procedure. Here is your globe, this gentleman in the center, and here's your lateral. It's split, and the hands of the lateral are now on the nasal side of the globe, and it centers the globe completely mechanically. How is it done? So let's take a look at this. Many people have called and asked, how do you do this? So there's fornix-based incisions placed supranasally near the superior oblique area and infranasally. And then there's a circumferential incision just anterior to the lateral rectus. I hook the lateral rectus and I perform an inferior oblique myectomy. Easy to do. Then you rehook the lateral and you clean it about 18 millimeters back. It's key to have an extremely long section of the lateral that is cleaned and brought over. You'll need 2 6-ovicruals. One is secured in the lower half and one in the upper half of the lateral rectus. You then disinsert the lateral rectus. And then, after doing so, completing this disinsertion, and you can see the 2 6-ovicruals, I use a scissor, Westcott's, to make an incision down the long arm. Some people use a hook to do so. But the key is to extend this incision back a good 18 millimeters or so. If you don't extend it back that far, it will be too tight and squeeze the globe as you bring it around. Then a gas hook is used to pass the inferior and superior halves around to the nasal side of the globe. Obviously, you're all familiar with using a gas hook. We've all learned to do so in retinal procedures or other procedures, but it's a safe way to bring those needles over to the other side of the globe. So there's your superior and inferior half brought over. At this time, I perform a superior oblique tenotomy, attaching the proximal end to a chicken suture, a 5-0 Merceline. And then I have use of the superior oblique if for whatever reason I cannot complete nasal transposition of the split lateral rectus. It's still sort of kept in the background for safety. If I'm able to complete the procedure, which is most of the time, I simply cut off the Merceline. So last steps. The superior half is secured just above the medial rectus insertion with an adjustable suture. And it takes some coaxing to advance each half nasally. The inferior half is secured just below the medial rectus. So here's that adjustable suture. And you sort of slowly pull on that adjustable and coax each half over to the other side of the globe. So I coax superior, then inferior, a little bit, bring it around until it's gently and softly placed on the contralateral side of the globe near the medial rectus. And then once that's done, I will cut the adjustable sutures much shorter in the typical short tag technique. And stick them under the conjunctiva so they're nicely hidden. At this point, since I've successfully done the procedure, I've long since removed that 5-0 Merceline on the superior oblique. And what you see under anesthesia is what you get. If the eye is centered, it will be centered when the patient wakes up. Where does the split occur? You can see from this axial T1 view, the posterior border of the split lateral rectus and each side is behind very posteriorly on the globe. Here's a case of a unilateral congenital subtotal third nerve palsy with a child who is about 2.5 or 3 years old. It's actually fusing with his head tilt and head turn. You can see he has limited elevation, limited introduction, and inability to abduct past midline, but clearly some capacity to use that medial rectus. Here he is post a single muscle procedure, nasal transposition of the split lateral. I actually did not do superior oblique tenotomy in his case, and you resolve his torticollis by doing this procedure in this case. Here's a newborn with bilateral complete third nerve palsies, which is for all of us who treat third nerve palsy, there's nothing better than having a bilateral third nerve, because if you can center both eyes, you have a much better view and much better cosmesis than treating a unilateral third nerve palsy. Here he is, MRI hypoplasia of both third nerves at birth. Here he is post placement of bilateral Seife suspension rods to open the lids. Here he is, bilateral nasal transposition of the split lateral rectus performed at 7 months of age. And here he is stable at 6 years. I've seen him now through 11 years of age, no change. And I think one advantage of this procedure is its relative stability. Here he is, courtesy of Josh Kruger, a friend from Hadassah Hospital, a gentleman who had bilateral third nerve palsies acquired, who chose to do one eye at a time. And here he is post bilateral nasal transposition of the split lateral rectus with a nice outcome. So how can we accurately appraise a novel procedure used to treat a rare disorder? We decided to do a REDCap international survey of outcomes published in BJO back in 2021. We had 98 patients with the procedure done at that point, median age about 33 years. The etiologies were what you would anticipate: about a third congenital, 16% neoplastic, 15% traumatic, and small numbers of other sources. 25% of these patients had had prior ipsilateral strabismus surgery on that eye for third nerve palsy, all of them with very large lateral rectus recessions and some other procedure. In this group, the median exotropia decreased from 70 prism diopters pre-op with an interquartile of 50 to 90 up to a really tiny amount post-op. We defined success rate as a Krimsky alignment in primary position of less than 15 prism diopters of exotropia and close to 70% success rate. We found that the most interesting aspect of this REDCap was that the procedure is self-correcting. If you have a small exotropia, 50 to 60 prism diopters, or you have 100 prism diopter exotropia, you have about the same rate of success. And I think it is self-correcting, because if you have a tighter lateral rectus, when you bring it to the medial side of the globe, because it is much more taut, it will pull the eye medially more effectively. So it is a self-correcting procedure. Adding a simultaneous superior oblique tenotomy at the time of the procedure enhances the power of the procedure. Why is that? First of all, you're eliminating any residual exotropic tone in the eye by getting rid of your superior oblique. And the other is that you have the advantage of getting rid of those incyclotorsional fibers. So if you have a patient who can fuse even in a small area post-procedure, that's a very nice gift you've given them. But we saw challenges. Technical challenges occurred in 30% of the cases, and almost all of them were in cases where the patients had had prior lateral rectus recession. More importantly, 11% of them had some kind of vision-threatening complication. We don't think of vision-threatening complications when we do strabismus surgery very often. These were independently associated with very posterior placement of the split lateral rectus muscle. Some providers chose to place that split lateral rectus very posteriorly on the globe, on the medial side, closer to the vortex veins, and we saw some compression in that area. So we found that if you place the split lateral rectus muscle less than about 4 millimeters from the medial rectus, in other words, much more anteriorly, you have a much decreased risk of serous choroidal effusion. If you place it posteriorly, you have an increased risk of serous choroidal effusion. So I would certainly recommend placing it much more anteriorly, as we do. Unusual complications, pressure on the optic nerve. We've seen one case reported. Very critical to split that lateral rectus at least 18 millimeters. If you do not split it enough, it'll be very tight around the globe. It can slip back towards the optic nerve. You need to be able to comfortably wrap that lateral rectus around the globe and insert it near the medial. All these technical aspects are really critical. Paradoxical increase in exotropia. I've seen this myself, and some have reported. If you place the split ends too anteriorly, anterior to the medial rectus, you will sort of pull the eye, toward the eye in the outward direction. Also, I had a case of this in an infant where I attempted this procedure at several months of age, and I switched to another procedure during the surgery. And I suspect it's likely best done after the first birthday. In my particular case, a bilateral case I showed you, it was done at 7 months of age. It went well, but if you have a very small eye, this may not be the ideal. Here's a good example of a patient who had prior strabismus surgery where I had to switch to a different procedure while attempting to do a nasal transposition of the split lateral. 62-year-old with a congenital third nerve palsy. He had 2 prior strabismus surgeries in childhood, and in addition to the strabismus surgery, he had a levator frontalis sling. He presented with a long-standing, persistent exotropia and a massive scar tissue in the nasal fornix. We were unable to obtain any operative notes, but during the surgery, it was very apparent that he had lots of surgery performed on the medial as well as the superior oblique and an extremely large lateral rectus recession. The left eye could hardly move at all. He had a preoperative exotropia in the 70 prism diopter range, and the rest of the sensory motor exam is quite apparent and listed here. So I attempted nasal transposition of the split lateral rectus. I would not do that at this time. This was early in my experience with this procedure. This was preoperative imaging, which I did to try to understand where that lateral rectus was. The lateral rectus was found about 16 millimeters from the limbus. It could not be effectively transposed. It was too short and too taut to possibly create those long arms that you need to go around the globe. So I abandoned the thought of doing the procedure during surgery, and I essentially further assessed the lateral rectus. I did another re-resection of his medial rectus. The superior oblique I resected and placed near the medial, and by the way, put on some traction sutures so you can perhaps see the bolsters above and below. I can tell you that I had a great outcome that lasted about 6 to 8 months. By a year and a half later, he had begun to develop some exotropia. So I think the traction sutures help, but if there's any lateral rectus in the room, any place near the globe, and able to attach to the globe, you probably will see some return of exotropia over time. And here this Prolene and bolster used to keep the eye centered. And I think I kept this on about a month. So what's my overall impression of this procedure? First of all, it's not for everyone. It's not for every surgeon, and it's not for every patient. It is largely self-correcting. And it's a great procedure if you haven't had prior surgery on the eye for the third nerve palsy. It's also, I think, quite stable over time. It's much harder to do if the patient has had a prior lateral rectus recession. The lateral rectus is too short and too taut to safely wrap around the globe. The split ends are best left close to the medial rectus insertion. This really significantly reduces the risk of any posterior compression and serious choroidal effusion. The alignment you see under general anesthesia is what you get. No big surprises when the patient wakes up. And we will be talking, Sean Donahue will be talking about procedures where you have aberrant regeneration. We actually looked at the subset of over 150 patients who had this surgery and sequestered that group who had aberrant regeneration. And we found that when aberrant regeneration involved the lid, it was fine. But if aberrant regeneration involved other extraocular muscles, I would not choose this procedure for such patients. Thank you very much. I enjoyed the opportunity to speak here today.
Thank you, Linda. Rosario, is you presenting Federico? And we will discuss
Go
later.
ahead. Yeah, you go ahead.
Okay. So next speaker, and thank you, Linda, again. Next speaker will be Federico Velez from Los Angeles. And he will speak about caruncular fixation and superior oblique surgeries. And we will discuss both presentation together at the end of Federico's presentation. Please, Federico, go ahead.
Right. To confirm, good morning. Just to confirm, can you see my slides? Can you hear me?
Yes, we do. Yes, we do.
Okay.
Yes, Federico.
Okay. Thank you very much for having me here, inviting me to be in this panel. And I don't have any disclosures to report with this presentation. I just want to bring my thoughts and prayers to all the people in Los Angeles, California, who are suffering with such a devastating nature disaster. And many of our colleagues are also suffering big losses here. So I'm going to mention two surgical procedures that I personally like. And thank you for the opportunity to present this caruncular fixation, a procedure that was introduced to me by a Brazilian author, Dr. Horta Barbosa. So Dr. Horta Barbosa at a CLARE meeting back in 1987 presented a surgical technique where he used Mercilin, 6-0 Mercilin, to fix the caruncle near the limbal area after the conjunctiva had been excised. This was in combination with a lateral rectus muscle recession of 12 millimeters and a traction suture. The key factor for Dr. Horta Barbosa was a positive force reduction test intraoperatively and an isotropic position deviation at the very end of the surgical procedure. So with Dr. Tanya Glazer at Duke, during my time at Duke University, and I want to thank Tanya for putting this together, we actually start working on this procedure. So this video will demonstrate some basics of the technique. We mark the caruncle, the conjunctiva is excised. And Tina Rutar was a co-author in one of these procedures, and she had the idea that this conjunctiva that we actually remove from here can be transposed laterally since the patient is having a tight temporal conjunctiva. And this is important because the tight conjunctiva will pretty much undo the surgical procedure. And basically we fix the conjunctiva or the caruncle near the limbal area using 3 independent or isolated sutures. I use 6-0 sutures, and I fix them to the limbal area, 1 in each corner, 1 in the middle. And lately, I've been using a 4th suture that basically holds the conjunctiva in the middle. So I just basically put this 4th suture some millimeters posterior to the new insertion of the conjunctiva, just to keep it flat, and it helps to secure the conjunctiva much better. I'm going to present you a few cases. I'm going to present the first patient I ever operated on, and I'm going to just present this video, which unfortunately the quality is not that great, but I just want to show you that after the lateral rectus muscle is being disinserted, I did this surgery under topical anesthesia. You see that despite of the lateral being disinserted, the patient cannot pass the midline, which I think is very critical when we're treating patients, because many things that we call completely paralytic situations, when they are associated to a tight ipsilateral but antagonist muscle, it's very difficult or almost impossible to determine if the muscle has any action. And I still think that if you have any kind of potential action of what you consider being a weak muscle, that would be the best surgical procedure, much better than any transposition or any fixation we do. Resect that muscle will work better than anything else. Anyway, this patient had a complete Turner palsy affecting the right eye, and we performed this caruncular fixation. Here you're going to see the patient in the preoperative alignment, and you can see that the patient reached the midline almost, but it doesn't pass the midline. And postoperatively, which is really very interesting, the patient still has abduction rotation, which is one of the things that I like about this surgical procedure. Despite of doing a lateral rectus muscle recession, as you can see here, and as Seyhan mentioned, I totally agree with what she said. Even if a muscle is paralyzed, doing some kind of anchoring medially procedure, like the medial rectus plication, in this case was just application, it can help as a traction temporary suture or anchoring or some medial tightness that help this conjunctiva to heal better, to keep the sutures in place. And it can help with the final outcome. I think so. But what is really interesting is that these patients still have good abduction motility, something that I don't achieve with many of the other procedures that I have done for a complete Turner palsy. Patient number 2, this is a patient that had, as you can see, a complete Turner palsy. So the decision here was not only do the caruncular fixation, but we decided to also do a nasal transposition of the vertical rectus muscles medially. And the postoperative outcome of this patient is excellent. But as you can see, in this situation, there is significant limitation to abduction because, as Linda just presented her wonderful job, the medial transposition of the lateral rectus muscle is definitely a tightening procedure that fixes the eye almost in the primary position with very limited horizontal ocular rotations. And just to show you something interesting, over time, this conjunctiva flattens and it doesn't retract posteriorly. And this is critical for this surgical procedure. You're basically creating a symblepharon. And I probably will say something that it may help when you're doing this procedure. If you dissect the conjunctiva too much, the conjunctiva is too free to hold the eye in the position where you want it. So yes, you have to do a little bit of dissection, but try not to do a complete free conjunctiva from all the underneath connective tissue, because probably it's not going to really hold the eye in primary position or wherever you want to put it. This is a very interesting patient because he had a previous large lateral rectus muscle recession, but the patient had a severe limitation to adduction, and the patient has a large angle exotropia. So what did we do? We did a caruncular fixation. I injected the botulinum toxin, and I resected the medial rectus 10 millimeters. So the patient is really isotropic in the first postoperative follow-up exam. But in the long term, patient had a large angle exotropia, as you can see here, and he cannot move the eye in the adducting procedure. So what did I do? I'm going to stop this because of the noise, but I'm going to explain what I did. So what I did is I went back to the lateral rectus muscle that had been recessed to 20 millimeters. And just by recessing the lateral rectus muscle and recessing the conjunctiva, the patient had an excellent post-operative outcome. It still has very good adduction and reaches the midline, similar to the first case I just presented to you. And this is a patient with a congenital Turner palsy who had had a previous lateral rectus muscle recession and has a significant exotropia in the primary position. So the first procedure I did on this patient, because the lateral had been recessed before, was just the caruncular fixation and a superior oblique nasal transposition, which I'm going to refer in a few minutes. But the patient did very well at the very beginning, but it was undercorrected. And I didn't want to go back medially. So what I did was I went back to the lateral rectus muscle and I recessed it to a position 25 millimeters posterior to the limbus. And this is the postoperative outcome of this. Oh, excuse me. And this is the postoperative outcome. Excellent alignment in the primary position. The patient has no adduction rotation. He has a little bit of abduction rotation, as again is seen in all the patients that I have done, except the patient who was combined with the medial transposition of the lateral rectus muscle. So I want to summarize that caruncular fixation is a very simple anchoring procedure that will actually still provide you with some horizontal abducting rotation. You don't need to have the orbital team. You can save the orbital team if you want to do a periosteal fixation or something similar to that. It can be combined with many other procedures, but in my opinion, the clue procedure is a large ipsilateral recession of the lateral rectus muscle. Now, what about superior oblique transposition? So I'm just going to say a few words about this procedure. The first reference that I can find about this superior oblique transposition is actually coming from a work done by Ciancia and Prieto Diaz, doing something different. They're actually describing a superior oblique posterior tenectomy and superior oblique recessions. And when they placed the superior oblique anterior to the equator, they actually found a complication, which was the patient couldn't depress and the patient ended having esotropia. Alan Scott later described in the American Orthoptic Journal the transposition of the superior oblique medially to treat patients with Turner palsy. And this is a very interesting analysis done with the orbit medially to treat patients with Turner palsy. And this is a very interesting analysis done with the orbit software. But basically, Alan Scott, Harley Vickers, also from Brazil, and a group of people from Germany confirmed that actually when the superior oblique is moved to the pre-equatorial position, it doesn't matter if it's nasal or temporal, I'm just saying pre-equatorial, the superior oblique loses the downward movement and it becomes more like a hyper elevator, especially in down gaze, but it also becomes an anti-abducting muscle. And at this point, what you're trying to do, which is bring the eye inward, then it's effectively caused by this pre-equatorial transposition of the superior oblique. And I'm going to actually show you a patient in whom I intentionally placed the superior oblique anterior to the equator because the patient had an elevation limitation persistent despite of multiple procedures. And you can actually see how much esotropia this procedure causes in attempted down gaze. Just look at this video. When the patient looks down, the huge down gaze isotropic deviation. And now you're going to see. Look, this procedure is a very strong adductor when the superior oblique is placed anterior to the equator. So what is the modification that I have introduced to my practice? 3 of them. I'm going to mention 2 here, and then next video I will show you another one. Is depending on the vertical deviation the patient has, I decide to put the superior oblique closer to the medial rectus insertion or away from it. Because if you put it closer to the medial rectus muscle insertion, you're going to create a hypertropia. So if you have a patient that has a hypotropia to begin with, then placing the superior oblique next to the medial rectus insertion is great because it's going to bring the eye in the upward position. You're going to create a hypertropia. But if you have a patient that to begin with is orthotropic or by any situation has a hypertropia, do not place the superior oblique there because your hypertropia will be much worse post-operatively. And then with some colleagues at Duke as well, we introduced this procedure after I discussed with Alan Scott. Alan, I mentioned to him, what would you think happened if the superior oblique is placed temporal to the superior rectus? In other words, if the superior oblique is reinserted next to the lateral rectus muscle insertion. And this is a patient with a complete Turner palsy, traumatic. We actually move the superior oblique just temporal to the superior rectus next to the insertion of the lateral rectus. And the effect is very similar. My idea was that if it's temporal, you may create a larger movement just because there's more tendon to pull instead of an anchoring procedure when you place it nasally. So the pre-equatorial superior oblique transposition, the rationale is that it becomes an anti-abducting. It also treats the hypotropia that you have in these patients because the only muscle that is functional is the superior oblique. And just keep in mind that it can induce hypertropia. I want to acknowledge all the people that have been involved in this project. We still have to publish one of them. And I want to thank you very much. We have to be as strong always and fight hard. Thank you. I appreciate it.
Thank you very much, Linda and Federico, for these very dense talks. And first of all, Linda, there are some questions, especially in the sense you are unmuted, Linda. Okay.
I'm muted, but well, let me start my video because the host has stopped it. You have to.
Okay.
Okay, there we go.
Yeah.
Great.
So some people ask about, you said, but about the fact of disinserting oblique muscles associated to your surgery, if you still do it or you don't do it, or you do it in some cases. And secondly, if you are dealing in a case that has already recessed the lateral rectus, how do you act? I mean, do you place the sutures closer, less closer, or from the beginning, you don't do any nasal transposition when the lateral rectus is recessed?
Okay, these are excellent questions. With respect to the obliques, I always perform an inferior oblique myectomy. Certainly that's not a big deal to do, and in any case, the inferior oblique is not functional, but it makes it easier to slide the inferior half of the split lateral rectus to the nasal side. There's just less tissue there, nothing for it to get caught up in. I always perform a superior oblique tenotomy in every case, and I always put in that chicken suture so that I have access to the superior oblique to do one of the fun procedures, perhaps that Federico has described, or simply place it near the medial rectus insertion if for whatever reason I am technically stymied and cannot pull the two ends of the medial rectus far enough. I think the biggest question is case selection. There's a few things I've learned over the years. When I first started doing this procedure, I was sort of doing it on every complete, subcomplete third nerve palsy that walked in the door. And over time, we all get a little smarter with our surgery as we learn from our patients. A few things. At this point, if someone's had a large lateral rectus recession, anything more than maybe 4 or 5 millimeters, and they almost never have that kind of a small recession. They've usually had 8 to 10 millimeters recession. Someone has tried to treat their third nerve palsy. I really do not at this point attempt nasal transposition of split lateral rectus. It's not a technically easy procedure to perform. I'm much more concerned that even if I can first of all, can I split the lateral a good 16, 18 millimeters? Chances are not, and not safely, because I'm now cutting back in areas posteriorly that I cannot see, right? And I do not want to place that scissor or hook way far back behind the orbit, behind the globe. The other thing is I'm afraid if it's too short and too posterior, I have a greater risk of this serous choroidal effusion. So essentially, if I have cases that have had a large lateral rectus recession, at this point, and that could change over time, at this point, my go-to procedure is usually something that Sean Donahue introduced to me, which is sort of a very large resection, extirpation of the lateral rectus muscle, kind of throwing the lateral rectus behind the eye, and either a large medial rectus resection, maybe pulling over the superior oblique. It depends, once again, if I have a hypo or hypertropia. I have found that that's, the biggest problem we have with third nerve palsy is recurrence of the exotropia, and you get very little recurrence. One other issue, which Federico hinted at, which is a real issue, is not every patient is ideally happy if you centered the eye, if the eye does not move at all. And so in cases where you can preserve some lateral rectus function, they often feel that the appearance is more natural. So in cases where I sense that's an important issue, I might do a supramaximal recession combined with something to tighten the eye medially, one of the many procedures that have been or will be discussed today. I have not had great luck hiding the lateral rectus on the lateral orbital wall and not having it return to a very substantial function. So I think it really needs to be set super far back and not with a hangback, either placed very posteriorly on the globe or this lateral rectus extirpation.
So thank you very much, Linda. There are many, many very interesting questions in the chat about the technique and about how to go first of the inferior, superior, but in matter of time, we have to switch to Federico. And Federico, about your caruncular approach, there's a comment about it is the semilunaris plica instead of the caruncula, that we should say, probably that's a comment, but my question, Federico, that seems a quite easy technique. Well, if we compare with other third nerve palsy techniques. And do you use it also in cranial desynerval syndromes?
Yeah.
I mean, is it strong enough to pull the eye, for instance, in one of the CEF cases?
Okay, so I appreciate that question. I only done it in one patient with a congenital fibrosis of the extraocular muscles that I saw. And for whatever reason, the patient had an exotropia, but he had the diagnosis of congenital fibrosis. He had previous surgeries. And honestly, I did the procedure not so much to regain any movement or anything. It was just because the patient said that nothing has been done before for him had worked, and he had not really any extraocular muscles. So the only thing that was left here was conjunctiva. Very limited outcome, in my opinion. I have to tell you a couple of things, because I believe the biggest challenge here is that the sutures stay intact when you actually place them. That's why I put 6-0. I know Dr. Horta Barbosa use Mercilin. I only use Vicryls or any dissolvable sutures. One of the technical issues that I want to mention very briefly are the following. Try to put the suture on a way that the knot will be under the conjunctiva. So start on the sclera, come through the conjunctiva, go again through the conjunctiva, and when you tight, your knots are covered, because they're really going to bother your patient. That's really something very important. I have to even tell you that in one patient, we wanted to compare if using any fibrin glue would have helped to keep the conjunctiva intact. In other words, we fix the conjunctiva in one eye with sutures, the other one we put the glue, and by the weekend the glue had just broken, the conjunctiva went back to where it was before, so we actually had to reposition the sutures. So I think that that's the clue. And that fourth suture that I put in the center is something that I actually learned from Ed Buckley, who actually liked to do in very large resections, that he recommended to put that suture. It's kind of like a stopper. You put it in the middle, keep that conjunctiva flat, fix on the sclera, and I think that that's really a major player for this surgical procedure.
How much do you suggest to leave the eye in for the audience?
No, I don't play.
No,
because I don't do traction. I don't do traction sutures. So I mean, the reality is that whatever the final position is my final position. So I cannot trigger how much esotropia this procedure is going to create, because I'm advancing it could be caruncular or semilunaris. I advance it, and then I recess the lateral rectus. Whatever that's going to give me in the primary position is different. I don't know. I'm not going to tell you that it's 15. The 15 that Dr. Horta Barbosa achieved was actually not from the procedure, but it was from the traction sutures, because he placed traction sutures to bring the eye into a deduction. So with that, you can say, okay, I want the eye to be in a 15 prism diopter of esotropia. But this procedure will not cause an esotropic deviation unless you do a very large resection of the ipsilateral medial rectus or application. But that's a temporary procedure, because that medial rectus is dead, as you saw in the two videos that I presented today.
Well, thank you very much, Federico, and we appreciate very much having you here today with the situation in Los Angeles. So we are going to switch to the next speaker in terms of time, and that will be Dr. Seyhan Donahue, and he's going to speak on the, do you have it on?
Yeah, I think it should be up. I don't know if you can see it or not. I'll try to share it again. All right, you got that there? Looks like it.
Yes, yes, now the full screen.
Yes, how are we now?
Okay,
Rosario?
thank you. Perfect.
Yeah, great. Thank you. On behalf of APOS, greetings from America, and I want to welcome all of you to this. And I want to also let everyone know about the annual APOS meeting, which is in Salt Lake City, Utah, March 5th to 8th. Salt Lake's a wonderful location. It's a Delta hub. It's easy to get to. It's in the Mountain West, and so in a great area. And I'm hoping that many of you decide to come and visit and see that city and see a great meeting. We've got an excellent program set up with many of the same speakers that you have here. I wanted to talk a little bit today about strabismus surgery and our outcomes in patients who've had aberrant regeneration of the third nerve. And you heard Linda mention a little bit about it. I want to thank Nilu Rahani, who is one of our residents who put this together for us. There's really two types of aberrant regeneration of the third nerve. The one that we see most frequently is secondary aberrant regeneration. That's after trauma, after nerve compression from a tumor. And one of the reasons we wait so long, and like Seyhan said, to wait a year, is to make sure that the nerve doesn't come back. And if it does come back, that it comes back in a way that isn't aberrant regeneration. That's secondary aberrant regeneration. But a much rarer cause is primary aberrant regeneration. And that's when you see a third nerve palsy and you see some signs of aberrant regeneration, but there's no history of any antecedent third nerve palsy. That's always problematic because you need to worry about a problem. This is a patient who came to see me, and you can see his eyelid. It's a left eye. He came in to see me with double vision on attempted down and right gaze. And you see as he looks down and right, that eyelid comes up. Now, there's also a little feature of primary ocular neuromyotonia here, which I don't want to get into, but as he looks down, do you see how that lid doesn't go down? It stays up. And that was his only complaint. This had happened for about 6 months. I was concerned about primary aberrant regeneration. We imaged him, and you can see this large mass in his cavernous sinus. It's been there for a long time. You can see it enveloping both carotids in the skull base. He's in the middle of a workup right now and following him because he has no other symptoms. So this is just a red flag when you see primary aberrant regeneration. These patients need to be imaged. Anyhow, with what I wanted to talk about today is our patients we operated on who had aberrant regeneration of the third nerve, primarily not just to identify and describe the regeneration patterns that are seen, but also to talk about some of the surgical principles that others and I have developed to use in these patients. We had 27 patients that we operated on who had characteristics of aberrant regeneration of the third nerve. One had primary aberrant regeneration, 26 with secondary. And the most common causes were what you would expect: traumatic third nerve palsies and an aneurysm. These are three different examples of aberrant regeneration of the third nerve and the three most common causes that we saw. On the top one, 63% of the time, patients had aberrant regeneration from the medial rectus to the eyelid. This has been described before, and the surgical treatment of this has been described before. But I want to point this out to you. This patient has a right third nerve palsy, and you can see when he looks to the left, that right eyelid goes up. And that's because aberrant regeneration has happened from the medial rectus to the eyelid. The second most common cause, most common association we saw, was from the inferior rectus to the eyelid. This is a patient with a left third nerve palsy, very similar to the video that I showed to start my talk. And when this patient looks down, The eye gets down all right, but the eyelid goes up. And that's a sign of aberrant regeneration from the inferior rectus to the eyelid. 56% of the patients had that. And then the third one, which was the primary motility abnormality that we saw, was when there was aberrant regeneration from the superior rectus to the medial rectus. That manifests itself by an increasing esotropia or a decreasing exotropia on upgaze, because the superior rectus gets connected to the medial rectus. And so on attempted upgaze, the eye drifts in. And those are the three groups that I'm going to talk about today. Many times patients had multiple aberrant regeneration patterns, and unless you look really carefully for this, you're going to miss it. So you want to look specifically first. Do I see anything in the eyelid? And watch that eyelid when the patient moves into adduction to see if the eyelid elevates, or when the patient looks down to see if the lid drops. The second thing to look for is on the pupil. And if you see, especially when you look down, you can see the inferior rectus oftentimes connects to the pupil instead. And then you'll see the pupil get small, and you'll see anisocoria with that eye having the smaller pupil on attempted downgaze. And the third one is to look for his motility patterns. So when the patient looks in different directions, specifically in upgaze, to see that that eye goes in. So you want to watch individually when you're examining the patient to look for each of those three. We had three strategies to cover each of those three different types of aberrant regeneration. This is the first one, and it's been described before. It was first described, as far as I know, by Monte Del Monte and his group probably 20, maybe 30 years ago. And this is a patient I showed initially. There's aberrant regeneration of the third nerve on the right side. And when the patient looks to the left, the eyelid comes up because there's aberrant regeneration from the medial rectus to the eyelid. All of these three strategies utilize operating on the fellow eye, in other words, the fixating eye. And what you do is you do XT surgery, moving the unaffected medial rectus and tightening it, and loosening the lateral rectus. So you move the fixating eye in adduction. This increases innervation to the non-paretic lateral rectus. That's yoked to the paretic medial rectus, and it raises the eyelid. So not only do you get the XT taken care of, but you get the eyelid taken care of as well. And so the nice part about this procedure is you are able to help treat the eyelid ptosis as well as the exotropia. Remember, when you do that, that you need to take your measurement with your prism over your non-paretic eye. So you're measuring and operating for the secondary deviation. In our patients, and there were about 8 of them, and you can see the deviation in this table. A couple of these patients had extirpations of the lateral rectus. Linda talked about that a little bit. And what I'll do is I dissect all the way back to where the lateral rectus goes into tenons. I'll clamp that right there and then resect that part out, cauterize it, and then let the muscle go back into tenons, just like if you were doing an inferior oblique myectomy. That takes most of the lateral rectus force away, and I have had very little problems with it recurring for very, very large angle deviations. So I did this in the contralateral eye because of a very, very large secondary deviations. And you can see we got an average improvement of about 25 prism diopters, and many of the patients did exceedingly well with one surgery, again, on the fellow eye, the non-paretic eye. This is an example of the patient we talked about before, where we did surgery for his exotropia on the fixating eye, and it raised the eyelid very nicely. The second strategy is patients who have aberrant regeneration from the inferior rectus to the eyelid. So the previous one was medial rectus to the eyelid. This is inferior rectus to the eyelid. So instead of the eye going all the way down, the eye doesn't go down as well, but the eyelid goes up. Again, here you operate on the fixating eye also. Note that this is a left third nerve palsy with left-sided aberrant regeneration. So you have a relative right hypotropia. So I'll recess that inferior rectus on the right side. That brings that right eye up and then increases tonic innervation to the depressors, increasing the tonic innervation to the depressors with a posterior fixation suture, helps raise the lid, and helps the vertical alignment. These are usually small angle deviations, but you're helping in down gaze. And this has been described for patients with vertical deviations that are incontinent, often with fourth nerve palsies. But with aberrant regeneration to the lid from the inferior rectus, I like to use this here too. And you can see we got the really very nice correction of the vertical deviations and improved field binocular vision into down gaze. The third strategy is for patients who have motility aberrant regeneration. And this one is patients who have aberrant regeneration from the superior rectus to the medial rectus. This is an example of that. This patient, again, in the left eye, when he attempts to look up, the eye goes in. So what you want to do is to take advantage of that by weakening the elevation ability of the fellow eye. Again, we're operating in the fellow eye. The superior rectus recession on the right side with a Faden suture. We move that non-paretic eye down. That helps improve the tonation to the elevators, improves the vertical alignment, and helps the exotropia as well. And so we improve the exo deviation in these patients by about 16 prism diopters and the hypo by about 10 prism diopters. And you can see in the final column over there that the vast majority of them were within 1 or 2 prism diopters of ortho and primary position. And then we can use, if necessary, an additional prism and a bifocal to help on down gaze. So of those, from our outcomes, we found that 93% of our patients had improvement of their versions and 90% had fusion within 10 degrees of primary, as well as improvement of their diplopia. So I've been really happy with these 3 strategies for patients who we're operating on who do have aberrant regeneration of the third nerve. There have been several other papers that have described this. The majority of them were having to deal with the exotropia and the eyelid. That's Mondi's paper with David Guyton that I talked about from 1980. And then recently in the Indian Journal of Ophthalmology, we had a nice paper about operating on the contralateral eye with a couple cases here for aberrant regeneration of the third nerve. So in summary, 3 strategies. The first is for patients who have aberrant regeneration from the medial rectus to the eyelid, operate on the non-paretic eye to improve their adduction and the eyelid position. The second is for patients who have inferior rectus, to the eyelids, so they're not depressing well, and again operate on the fellow eye with a posterior fixation suture to improve the position of the eye in primary position. And the third is for patients who have an abnormality where their aberrant regeneration is from the superior rectus to the medial rectus, and in those patients, a superior rectus recession with a posterior fixation suture. Again, on the non-paretic eye, works nicely. Remember to make your measurements of the secondary deviation. In other words, you're putting your prism over your non-paretic or your fixating eye, because that's when you're going to be operating on. In summary, most common regeneration patterns that we saw here are these 3: medial rectus to the lid, inferior rectus to the lid, superior rectus to the medial rectus. And these are the papers that I've talked about. So I really, again, appreciate all the people that have joined for this and my panelists as well, and appreciate the opportunity to have a worldwide seminar like this. Rosario, this has been great. Thank you.
You want me to? Yeah,
Yeah.
okay. I was waiting for
There you go, Giovanni. Thank you too.
No, thank you, Sean. We have a question from the audience. If for you, Sean, have you any tips to differentiate aberrant regeneration from a congenital synkinesis between the and the levator?
Good question. Usually it's within the history. The patients who have aberrant regeneration, almost all of them are going to have a history of a third nerve palsy. Usually it's traumatic or compressive from an aneurysm or a tumor within the cavernous sinus. And then, whereas patients with congenital synkinesis will have had that from birth. These are all patients that I had here were adults or later onset children and not a congenital abnormality.
Okay.
Linda, you got your hand up too.
I do. First of all, I love that talk. Thank you so much for delivering it. My question is, when do you do a larger inferior or superior rectus recession, and when do you use the posterior fixation sutures? That to me is like an interesting step in the decision making of what to do.
Yeah. So the first thing that I think is important for me when I measure these patients to look at their vertical fusional amplitudes. And I'll measure their vertical amplitudes about primary position. And then I'll measure their incompetence between primary position and up gaze in the superior rectus ones and down gaze in the inferior rectus ones. And if I see significant incompetence, and almost all of these third nerve palsies have significant incompetence, I like the posterior fixation suture to help with that incompetence. The amount of surgery they end up doing then is at the large amount of their fusional amplitude. So they may measure 3 prism diopters of a vertical and primary, but have the ability to fuse 8 to 10. Well, I want to try to correct that 8 to 10 because that will help me more in down gaze. So I will use that range of fusional amplitudes to determine the amount of deviation I correct in primary, and then I use the posterior fixation suture for up and down gaze.
Thanks.
Seyhan, please.
Thank you. So, Sean, this was a great presentation. So I have actually 2 questions. My first question is, did you consider a Scott procedure for making these surgeries on adjustables? I mean, by combining both posterior fixation and recession. And on the other hand, my second question is, in our hands, so the basic principle is using the Herring's law, but when you do it only with recessions, the eyelid effect usually wears off easily. So what we saw was that if it is combined with some effect of, if it works against the restriction, the effect lasts longer. And I would like to learn your opinion on that.
I'm familiar with Allen's procedure where you can resect and recess at the same time, and especially for vertical deviations and those with fourth nerve palsies. And Oscar Cruz and Gil Roper Hall wrote a really nice series that was much larger a few years ago, again for force. And then Brad Black's also talked about a resection with a contralateral recession of the other eye and the same eye, all in adjustable sutures. To me, I'm kind of a less is more person. And if I can think I can get most of this deviation with correcting the incompetence by doing one muscle with a posterior fixation rather than 3 muscles on adjustable sutures, I tend to prefer that. And most of the time the patients are happy and I'm not going back. Now, the idea of resection with a recession only of that muscle rather than a posterior fixation one is really an intriguing one. I've not done that. I've seen Oscar's paper and others. I think Federico's got a good series on that too, and he's got his hand up, so he may be able to talk about that better. But I think that would be just as reasonable of an option because it would correct the same things.
Yeah, well, actually, my question was that using not going on 3 muscles and so on, and just with 1 muscle, but to make these procedures unadjustable, could it be an advantage?
Yeah, it certainly would be, and because the advantage of that combined resection and recession is you can put on an adjustable very, very easily. I've not done that.
Thank you.
Federico, have you done that? You and I think we've talked about this.
You're muted.
Microphone.
Yeah.
Thank you.
So I thought that I unmuted. I'm sorry. I love doing that. I love doing the Scott procedure. I think to me, especially for the lateral rectus muscle, because I can really go way too far back, more than I feel comfortable doing a posterior fixation suture. And the people who do posterior fixation sutures or typical Faden procedures, they have the limitation in the lateral rectus muscle. I mean, a lot of people in Europe mentioned that it doesn't work as well. So I would say my experience is very limited on that. But can I ask you 2 questions, if you don't mind? One question will be this. In your group number 2, the patients that have the hypertropia and they have the aberrant innervation, if you just recess the inferior rectus in the other, it looked to me that this could be patients that have like an inferior branch Turner palsy on that affected eye, so the eye is up and out. And you have to find out also a misinnervation, not only to the eyelid, but also to the medial rectus in order for the inferior rectus muscle to work. Is that correct?
Yeah, so none of these patients were just isolated inferior or superior branch. I have seen those with aneurysms, but all of these patients had an antecedent complete third nerve palsy, and so this was a secondary aberrant regeneration. And then I think your other part of that was incompetence between primary and upgaze. Yeah, so these eyes just don't get down very well. They did not seem to have an associated medial rectus aberrancy as well. I think some of them did have both. There were multiple patterns seen in a number of them, but had they had a increasing ESO on attempted downgaze, I think I would have noticed that and would have done something for them. I don't recall seeing that much.
Okay, and the second question is this. I mean, and I don't know if you've tested this. I prefer to do a recession, but I think Seyhan's question is really very interesting. What will give you more? What will give you a more like an enhance or increase, whatever you want to call it, inherent slow to bring that eye in to help the eyelid? The recession or the resection? I mean, if you do a massive resection of the medial rectus on the fixing eye, that will limit the abduction, and still the lateral rectus will try to, bring that eye out. Will that be better? I think like you, but I wonder if you ever had an opportunity to test what is better.
Yeah, I've never done just a medial rectus muscle resection for these. And for the large ones, I do like the lateral rectus muscle resection with extirpation and letting it go. I also don't find the posterior fixation suture very helpful on the horizontal rectus muscles, and haven't used it at all, I don't think, for probably 20 years on the lateral. It may well be that the resection, that the Scott procedure, like Seyhan talks about, the resection plus the recession, may help that incompetence. I don't know. I may have to try that with the next one of these.
But the only thing about that procedure, but the only problem with that procedure is this: you're not just treating the incompetence. You're really, because when we do the reset procedure, it's usually mostly, or in most cases, for patients that have a good alignment in the primary position. So you still have to do a huge amount of recession or do a very minimum amount of resection to obtain the improvement that you need to go in the lateral gaze. Because in reality, that's what you're looking with the Scott procedure, not to change much the primary position, which is not the case of any of the patients that you're presenting over here, except the ones that will have good alignment in the primary position, which probably are not that often seen.
Yeah, the XTs are not going to have a problem, incompetence in primary. It's going to be the ones who from straight ahead to down gaze. It's the verticals, and that's why I think that may really work. That may really work nicely for them.
Okay, with these excellent speakers, the success was guaranteed. So I thank you very much for this very, very nice discussion. And please, Giovanni, if you can close our session and to introduce the next webinar.
There's the probably another slide. Yes, so thank you again to all the speakers, first of all. We learned a lot this 1.5 hours this afternoon. So I also suggest you to present this next hour webinar, which will be Saturday, 26th of April, 2025, on the orthoptic examination of the child. We have 6 very distinguished speakers with us. So let's see every one of you online in April. Thank you very much again. Tamara, do you want to say some words maybe? Are you still there?
I'm here. I just want to say thank you to everyone. It's been an extraordinary webinar, and I look forward to the next webinar with the American Association of Certified Orthoptics. And thank you all so much for your time and for your presentations. I learned a lot.
Okay.